morning, respected BC sir and respected senior faculty, dear colleagues and dear students. Today CCR from Department of Ophthalmology, a 38-year-old male with progressive diminution of vision with associated redness and pain. Our department is almost fully equipped with recent technologies and instruments. There are 2 units, including 2 professors, 2 assistant professors, 2 emeritus professors, 3 senior residents, and every year 5 PG residents are taking admission, and total 22 residents passed from our department since 2019. We are running specialty clinics. Almost all fields are covered on every day. Our department is almost fully equipped with latest technologies like street lamp with attached camera and with recording facility, optical coherence tomography OCT, which take the pictures of the retina and we can study layer by layer of the retina, perimetry or visual field analysis, Perkins tonometer, which is a handheld tonometer to record the intraocular pressure on bedside or sitting position. A scan to measure the axial length, which is a very important instrument in measuring the ion power. B scan is the ultrasonography. Retinal lasers, different green lasers are available. We have a separate OT with 2 microscopes. 1 microscope have teaching facility also. Non-contact tonometer and fundus camera. In department running OPD since inception of hospital, and every year we can see the graph which is increasing every year, and this year we may reach up to 45,000 OPD up to the last of this year. Different type of surgeries are performing in department: cataract, glaucoma, pterygium, corneal tear repair, squint surgery, vitreoretinal surgery, which include scalp fixation lenses, vitrectomy and retinal detachment. And recently, 15 days back, we have also done a case of refractive surgery. Surgical load, as we seen in the graph, is increasing year-wise. We are also arranging community outreach programs, and average yearly we are doing 48 to 50 camps, means 4 camps a month, and screening around 5,000 to 6,000 population, and the needy patients are referred to our department for the management at the minimal or no cost. We are doing free cataract surgery. The patient is screened in these camps. There are few achievements also. Total number of paper publication in last year is 16. Paper presentation in various state and national conferences are 25, and 2 of our agents also attending internal conferences. Now I will invite the Dr. Sophia for the further discussion of this case.
Good morning, honorable professors, seniors, colleagues, and my dear juniors. So, today we'll take you on an ocular journey of a 38-year-old male with progressive decrease in vision with intermittent redness and pain. Come on board with us. So the chief complaints of a 38-year-old male who was a resident of Junjunu, engineer by occupation, came to ophthalmology OPD with complaints of both eyes decrease in vision since 11 years. It worsened in last 1 month. He had redness and pain, which was on and off again since 11 years. In the history of presenting illness, the patient was apparently well 11 years back when he complained of gradually progressive decreased vision in both eyes with recurrent episodes of pain and redness 2 to 3 times in frequency per year, which improved with taking medication. Since last 1 year, he has been complaining of progressive, gradual diminution of vision in both eyes for both near and far distance, which is more marked in last 1 month, associated with intermittent pain, redness and photophobia. However, he was able to carry out his day-to-day activities without any assistance. In the past history, he had lower back pain since 2016, which relieved after taking painkillers. He was diagnosed as rheumatic heart disease in 2001. For valvular abnormality, he underwent double valve replacement and tricuspid valve repair in 2017. There was no history of hypertension, diabetes mellitus, tuberculosis or any trauma. He is presently on oral tablets of warfarin, diuretics, ramipril, bisoprolol since 2017. And there has been no history of any steroid intake. No history of similar complaints in parents or siblings. And he is a non-alcohol consumer, non-smoker, non-tobacco chewer, vegetarian, and his bladder and bowel habits are also normal. So summarizing the case on the basis of history, a 38 years old male, both eyes gradual progressive decreased vision since 11 years, which worsened in last 1 month, with episodic and recurrent painful red eye, associated with history of lower backache and post-operative case of RHT. What could be the possible differential diagnosis? Okay. Okay. Anyone else? Okay, so moving on. So these are some provisional differential diagnosis which we have kept. Uveitis and glaucoma. These can be there due to presence of red eye and pain. Cataract, as since the patient had diminution of vision. Cornea, again due to diminution of vision, and retina as well for the same reason. General physical examination. So the patient was alert, active, conscious and oriented to time, place and person. He was vitally stable. There is no pallor, icterus, edema, lymphadenopathy, cyanosis, clubbing, skin rash, joint or bone deformity. There is no limitation in any joint movement. On ocular examination, we found out that the uncorrected and the best corrected visual acuity was same. It was around finger counting 1 meter, and in left eye it was finger counting 2 meters. The head posture and facial symmetry were normal. Eyebrows were at equal level. Eyeballs were again normal in size, position and movements. Eyelids, both upper and lower were normal. The palpebral aperture was again normal in width and height. And the conjunctiva, both bulbar and palpebral conjunctiva was normal. The scleral findings, there were no discoloration or nodules found on sclera. In cornea, it was normal in size, shape, surface and sensations were intact, but it appeared hazy with decreased sheen, as you can see in the picture as well. There were small brown keratitic precipitates present in both eyes. The anterior chamber depth was normal, the cells were absent, but there is a 1+ slight flare present in both the eyes. In the iris, it was muddy brown in color and had a disturbed pattern. There is almost total posterior synechiae. There was no iridodonesis or nodules present on the iris. The pupil was 1 in number in each eye with size of 2 millimeters, irregular shape and margins, and it reacted only sluggishly at certain positions. On dilating the pupil, we found out that the patient had a festoon pupil. So festoon pupil is something which is found when a patient has some inflammatory condition in the eye, and due to formation of synechiae, the pupil does not dilate completely, thus it takes a festoon shape. So the lens was central in position, dirty white in color, and it had iris pigment deposition. The intraocular pressures for right eye was 16 and left eye was 18. The fundus appeared hazy and rest of the details were not visible. So here for the reference, the patient's pupil is shown on the left side. It is a festoon pupil, and you can also see a normally dilated pupil which is around 8 to 9 millimeters. Moving on to systemic examination, it appeared normal and there was a surgical scar over the mid-sternum area. So now, summarizing the case on the basis of examination, 38 years old male with both eyes gradual decreased vision since 11 years and worsened in last 1 month. He had episodic recurrent painful red eye with lower backache and was known case of RHD operated in 2017. He also had small non-dilating festoon pupil with posterior synechiae, dirty white lens and no fundal view. So what could be the provisional diagnosis now?
basis of history and examination, it could be chronic uveitis with cataract.
Okay, so moving on, yes, you're correct. So uveitis has been kept as one of the diagnoses. The second one is glaucoma, cataract and retina. We have removed cornea since after examination there were no findings in reference to corneal degenerations or dystrophy. So in uveitis, the uveitis can be classified as infectious, immune specific, idiopathic or trauma. Since there was no history of trauma, so we can remove trauma. Again in glaucoma, since the patient had red and painful eye, so angle closure glaucoma can be a cause. Secondary glaucoma can be due to topical steroid drops or any inflammatory reaction, but after examination developmental can be ruled out, and similarly in the cataract, developmental cataract can again be ruled out. But to find out the cause of all these conditions, we need to send investigations and see further. So finally we made a provisional diagnosis of complicated cataract with chronic uveitis in both eyes. After sending blood investigations, the ESR was raised. Then as the patient was a post-cardiac surgery patient, so his PT INR was again raised. It was 42.4 seconds with INR of 4.65. And since the patient had cataract, so we had planned him for a cataract surgery as well. So we had referred the patient to CTVS department where he was already taking treatment from as he was operated there. So they helped us in controlling the PT INR. And then before the surgery, the PT INR was 12.4 seconds. The serology was negative and he had RBS and FBS again in normal limits. So to rule out the cause of uveitis, we had sent some special investigations. Monto test was sent, which came out to be negative. Again for syphilis, VDRL was done, which was again negative. Rheumatoid factor was also less than 12. But we found out that the HLA-B27, there was target detected in HLA-B27. So a chest X-ray and a sacroiliac joint X-ray were again sent. So the chest X-ray appeared normal. Now to tell you about these special investigations in detail, I would like to invite Dr. Adhar Dhuria.
Very good morning to all of you. Thank you, Dr. Sophia and team of ophthalmology. So let me take you briefly through these X-rays. So when the patient was referred to us, the summary was a bilateral chronic anterior uveitis. He was HLA-B27 positive. There was some history of low backache, but it was not very prominent for the patient. So here we have two X-rays. This is the normal X-ray. So if you look at this, this is the sacroiliac joints. This black space between the two margins is the normal sacroiliac joints. Now if you look on the right side to you, you cannot make out any differentiation. So this is the modified New York classification. So this, it looks as if it's been drawn with a pencil. So this is actually grade 1 sacroiliitis. You just have some haziness. And if you see here, you have sclerosis on the margins, some blurring of the joint margins, and this is grade 2. This is grade 3, and there is a lot of destruction, and the joint appears wider than here. So look at the image above and below, it looks as if the joint has widened. That's because of the erosions. This is called a pseudo-widening. And this is what our patient actually has. This is grade 4, you can no longer make it out because the entire joint is ankylosed. So once you have grade 4 modified New York classification, sacroiliitis unextensive, that's more or less confirmatory for ankylosing spondylitis. Another differential could be diffuse idiopathic skeletal hyperostosis, but that will usually be in the upper part, not in the lower. So HLA-B27 is the most common identifiable cause of anterior uveitis, and the prognosis is less favorable if you are HLA-B27 positive as vis-a-vis HLA-B27 negative, because this is going to be recurrent. So how we as rheumatologists look at uveitis is, we ask the ophthalmologist see whether it is anterior, intermediate and posterior.
So here we had some iridocyclitis, but everything else, the vitreous and the retina were okay. So this becomes anterior. This was chronic because it has been there for some time. Recurrent we cannot tell because the patient has made a visit at the very terminal end of his illness. And it is bilateral. This has already been covered by Dr. Sophia. So there's a whole gamut of reasons for having uveitis under immunology. Idiopathic, GRA, angst-pond, HLA-B27, but no arthritis, sarcoidosis, reactive, SL. So almost all our causes cause uveitis, and that's why you have a very frequent relationship with the ophthalmologist. So how frequent? So I told you that the anterior uveitis, the most common identifiable all cause is HLA-B27. Without a surprise, the most common extra-articular manifestation in ankylosing spondylitis is also uveitis in 25% of the patients, and it increases with disease duration. So we'll not infrequently find people coming in their 50s with uveitis. You go back, do the X-rays, you find evidence of angst-pond, and the pain for some reason has been ignored. And complications are very common. So this was one study published in the Royal College of Ophthalmology journal. So they had a mean follow-up of 9.8 years, and 48% of the eyes had complications. And they found that older age, intermediate uveitis and chronic inflammation result in more complications. So we're talking about intermediate age uveitis, which will be seen in less than 10% of HLA-B27 patients. But the more you go posterior in the eye, the more you have problems. So intermediate and posterior uveitis are very troublesome to treat. So 40% of the patients in this study had posterior synechiae, which our patient also has. 22% had cataract, again had. So our patient has the two most common complications of HLA-B27 related uveitis. There are other extra-articular manifestations also associated with angst-pond. IBD, histological inflammation, lung abnormalities in CT, heart conduction of disturbances, aortic insufficiency. So this is a very rare complication. Here the patient had 3 valve involvement, tricuspid, mitral and aortic, which will almost never happen. So that is not related to the HLA. Thank you. I'd like to invite Dr. Sophia back.
Thank you, sir, for enlightening us with this information. Since the case was post-operative RHD, so we had to maintain an anticoagulant profile before surgery. So we referred a patient to the CTBS department. So I would like to invite Dr. Ashish Sharma, sir, to tell us more about this case.
Good morning, everyone. Thank you, ophthalmology department. So our role basically in this case was to maintain the coagulation while during the perioperative phase of the patient. As far as the patient details, you may only read a 38-year-old male with, as when referred to was in 2017, he was a case of severe mitral stenosis, regurgitation, severe tricuspid regurgitation with severe pulmonary artery hypertension. What we did was double valve replacement with the tricuspid valve repair, as the patient was young, so both the valve was metallic valves. Follow-up, the patient initial few years was regular. Both valve clicks were at every time, vitals were stable. Patient was in AF but in controlled rate. And INR was always in the therapeutic range, which is maintained between 2.5 to 3.5. The treatment which he was receiving was warfarin, diuretics and rate control drugs. My guidelines today are based on American College of Surgeons guidelines of perioperative management of the antithrombotic medications. The challenges and burden which we all have in these cases is like the temporary interruption of patient with anticoagulants exposes the patient to the thrombotic risk, and continuation of these agents increases the risk of bleeding. So currently, according to this paper, 1 in 10 surgical patients in US are prescribed chronic anticoagulation. And also it is seen that in the first 2 years following the start of the anticoagulation, about a quarter of these patients require discontinuation of the therapy for any other scheduled intervention. And moreover, in coronary stents, patient dual agent antiplatelet therapy is frequently given to prevent myocardial infarction and thrombosis of the stent. Anticoagulants like warfarin and echinocomedol are mandatory for the adequate functioning of the mechanical heart valves. So broadly, we divide our all patients according to the bleeding risk. This is a cumbersome chart, but broadly we can see that low, moderate risk and high risk. Low risk procedures are like dental extractions or cataract surgery, dermatological procedure, any endoscopy without taking biopsy, angiography. Moderate risk procedures are intra-abdominal laparoscopic cholecystectomy, hernia repair, general thoracic surgeries, colonoscopic with biopsies, and high risk procedures are spinal, epidural anesthesias, neurosurgeries, cardiac surgeries, major vascular surgery, lung resection surgeries, etc. So there are some diagnostic based consideration about in these cases. First, we broadly have 3 or 4 kinds of patients in which antithrombotic management has to be seen. First of all, there are non-valvular atrial fibrillation patients. For these patients, we always calculate Chadwell's score, which I'll explain in the later slides. And according to this score, if it is 4 with no risk factor, anticoagulation can be stopped safely and surgery can be done. But if the score is greater than 5, then bridging therapy has to be considered. Bridging therapy I will explain. And in mechanical heart, prosthetic heart valves, we have mechanical and bioprosthetic valves. For mechanical valves, we have to stop anticoagulants and bridging therapy has to be given. Bioprosthetic heart valve, they do not usually require any anticoagulants after 6 months of surgery until the fabric of the swing ring has become endothelialized. And if a patient with bioprosthetic valve is still receiving anticoagulation even after 6 months, then it is most likely that the patient will have atrial fibrillation or DVT or any other previous vascular surgeries. So for these, the guidelines are that elective operation should be delayed for 6 months after the implantation of the bioprosthetic valve. For non-elective emergency surgeries, we have to stop warfarin and proceed with the surgery. In coronary artery disease, as I said, dual antiplatelet therapy is always prescribed after stents, and risk of stent thrombosis is highest within the first 4 to 6 weeks of stent placement. Approximately 5% of these patients will require other surgeries in the first 2 years. So the guidelines are elective surgery should be deferred. In case of balloon angioplasty, simply done then 14 days. For bare metal stent, which are not usually used nowadays, 30 days, and drug elective stent, they are most commonly used for 6 months to 1 year. If surgical delays outweighs the potential harm of stent thrombosis, then in low bleeding risk cases, like I explained in the previous slide, dual antiplatelet has to be stopped and only single dose aspirin has to be started and surgery continued. And this aspirin has to be continued in perioperative period. For high bleeding risk cases, bridging therapy has to be considered. In peripheral arterial diseases patients, if there is no history of vascular surgery, patients are usually managed on platos, cilostazol, antiplatelet. They are stopped 5 days before surgery and to be restarted within 24 hours of surgery. In presence of venous or vascular graft, the bridging therapy has to be considered. In stroke patient, elective surgery has to be deferred for 6 months. In DVT or venous thromboembolism patients, if it is a history of less than 3 months, then elective surgery should be deferred. In 3 to 12 months, the bridging therapy has to be considered, and more than 1 year old, then bridging therapy has to be considered on the case-to-case basis, comparing the previous venous dopplers to the recent ones. So this patient comes in high risk, as I explained. We actually divide the risk stratified this patient according to their thromboembolism risk in high, moderate, and low. High risk comes mitral valve prosthesis, which are old one also and bileaflet also, and history of stroke or TI within the past 6 months. Moderate is bileaflet aortic valve prosthesis, a patient in AF, previous stroke, and low risk are bilateral aortic valve prosthesis with no other risk factors. Same is with atrial fibrillation, more than 6, Chadwick score, 4 to 5 or 2 to 3. And venous thrombolism, as I said, 3 months, 3 to 12 months, and more than 12 months. So this patient comes in high risk as he has a mitral valve prosthesis in situ, and double valve leaflet, aortic also there, and patient was in AF. Basically, these are the 2 scores which we follow: Chadwick score, which evaluates the risk of thromboembolism or the stroke, and Hasbled score, which evaluates the risk of bleed in the patient. Chadwick score is basically developed for patient management of atrial fibrillation who are more prone to stroke. So if there is the presence of heart failure, hypertension, patient is 75-year-old, is diabetic, history of stroke, any vascular disease, age between 65 to 74, or he's a female candidate, then every point is given 1 point. And that point where A2 and S2 is given if they are given 2 points, and we calculate the Shattuck score. Similarly, like Hasblad score, we have hypertension, abnormal renal function, abnormal liver function, stroke, bleeding, and unstable INR, elderly patient, or patient on drug or alcoholic. So according to this, our patient is low bleeding risk but high thrombotic risk. So now about the bridging therapy. Bridging therapy is basically substitution of a long-acting anticoagulant, usually the patient is on warfarin, substituting it with short-acting anticoagulant, usually a low molecular weight heparin, to limit the time of subtherapeutic anticoagulation levels and minimize the thromboembolic risks. Basically, there are 4 indications for this: presence of mechanical heart valve, stroke, any episode of history, systemic emboli or thromboembolism during last 3 to 6 months, fibrillation, and recent coronary stenting, previous 12 months. The basically what protocol we follow is we stop the warfarin or the anticoagulant 5 days before surgery, and we do a daily INR. When the INR falls below 2, then we begin low molecular weight heparin, 1 milligram per kilogram. Usually it comes in 0.4 and 0.6 subcutaneous injections. It is administered twice daily till 24 hours before the procedure. And INR is performed 1 day before the procedure. If it is more than 1.5, then the oral vitamin K 5 milligram can be given, and again the INR is performed in the morning of surgery, or intravenous vitamin K is still 2.5 given if the INR is still above 1.5. And warfarin is reinitiated within 12 to 24 hours of as per the previous dose. And again after the surgery, once the bleeding and everything is settled down, low molecular weight heparin is restarted about 1 to 2 days after surgery as post-operative bridging, till the INR is within the therapeutic range, and daily INR to be sent. In patients with renal insufficiency, unfractionated heparin is preferred over low molecular weight, which is renally regulated. Summary is like aspirin, no need to stop for low or moderate bleeding risk, and it is stopped 5 to 7 days before high bleeding risk, and surgery is continued. Warfarin or acetrom stopped 5 days before surgery, INR to be maintained less than 1.5. And antiplatelet drugs like clopidogrel, prasugrel, ticagrelor, or direct acting anticoagulants, they are stopped 5 to 7 days before, and all these drugs are to be restarted within 24 to 48 hours of surgery. In case of warfarin, acetrom, heparin or low molecular weight to be given until the INR, which is 2 in post-operative period. So what we have to remember that if the clotting risk is high and bleeding risk is less, then we have to stop long-acting anticoagulants and bridging them with short-acting anticoagulants. If the bleeding risk is high and clotting risk is less, according to the charts, and then stop the long-acting anticoagulants and no bridging is required, surgery to be continued. And there is a warning and that please do not forget DVD prophylaxis when it is appropriate. Thank you.
I would like to thank Ashish sir for enlightening us with this knowledge. Good morning. I am Dr. Srishti Arya, PG resident 3rd year ophthalmology, and I'll be discussing the case further. So our final diagnosis is complicated cataract chronic uveitis in both eyes, HLA-B27 positive ankylosing spondylitis. So our treatment plan was cataract surgery with intraocular lens implantation in the bag. We have 2 cataract surgery which we kept as an option for the patient: small incision cataract surgery and phacoemulsification. Small incision cataract surgery had lesser intraoperative complications in this case. However, there were chances of increased inflammation due to larger incision and iris handling, chances of more bleeding, requires injectable anesthesia. Phacoemulsification had smaller incision, lesser inflammatory reaction, lesser chances of bleeding, can be done under topical anesthesia. However, it requires a good dilatation and chances of serious complications intraoperatively. So the management challenges in this case, the first being small pupil. So it gave us less visualization, leading to limited workspace, excessive bleeding, difficulty in creating good sized capsular excess, iris sphincter tear if caught in phaco-pro, iris damage or prolapse, increased inflammation post-surgery with exudative membrane formation. Our second challenge being, our patient was on blood thinners. Peribulbar block may cause retrobulbar hemorrhage, increased chances of bleeding from iris, and suprachoroidal hemorrhage. Though our case was planned under local anesthesia, we would like to thank our anesthesia team for their amazing backup in the OT and helping us during our emergencies. So two types of local anesthesias was planned, injectable and topical. Injectable being peribulbar anesthesia, which provided us with better anesthesia. However, there were increased chances of hemorrhage and optic nerve injury. Topical anesthesia, the anesthetic drug which was used was proparacaine, 0.5% eye drops. No injection was required. However, there were increased chances of pain during maneuvering and no echinacea achieved, so the eye had to be operated on a moving eye. How we overcame these challenges? Mydriasis to tackle the small pupil. So the drugs which were used were intracameral injection of phenocaine. So phenocaine is a combination of lignocaine 1% plus phenylephrine 0.1% plus tropicamide 0.02%. Intracranial adrenaline, viscodilatation. Mechanically, it could have been done by pupilloplasty, iris hooks, malleum ring, and Behes rings. Now I would like to show you our surgery. So our right eye was planned for phacoemulsification under TA. As you can see, the pupil is not dilated. We have to use the iris hooks. So the first iris hook has been placed, and with careful precision and at equal distance, the second iris hook has also been placed into position. Two side ports will be made with a paracentesis blade for the entry of the third and the fourth iris hook as well. After placing all the iris hooks, the silicone sleeves are tightened, and as you can see, mechanical dilatation of the pupil is achieved in a rectangular configuration, providing us with a clear view of the cataractus lens. Now visco has been inserted, and with the help of a cystitome, capsulorhexis is done. So capsulorhexis is a procedure in which the anterior capsule is turned in a circular fashion, keeping in mind to be careful of not damaging the iris. It is carefully torn in a circular fashion. The visco is inserted. Now hydrodissection is done to separate the cortex from the nucleus. Visco is inserted again. So visco here is inserted again to maintain the anterior chamber as well as to protect the endothelium of the cornea. Another side port is being made to insert the phaco tip and a chopper. So here, nucleectomy is done by stop and chop method. Here the nucleus is divided into two equal quadrants and further emulsified with the help of a phaco aspirator and a phaco tip. The phaco tip is made of a titanium blade which vibrates at a speed of 40,000 Hz per minute, and each quadrant is emulsified and aspirated. After aspiration, you can see some selective cortical matter has been left behind. Again, visco is inserted into the anterior chamber to maintain the anterior chamber. As major of the work is done, one of the iris hook is slowly removed. The remaining cortical matter is aspirated with the help of aspiration and irrigation technique. Now the lens is placed in an injector with some visco and inserted through the small incision from where the iris hook was removed. The lens is injected in place and placed centrally and dialed with the help of an IOL dialer.
You can see the IOL has been placed centrally in the back. Now the remaining two silicone sleeves are loosened and the iris hooks are removed. As you can see, there was no damage to the iris, which resulted in not having any excess bleed. Our incisions are so small that no sutures are required, and the sections are healed with hydrodissection, keeping in mind that the anterior chamber is well maintained. After surgery, post-operative day 1, uncorrected visual acuity of the patient from 1/60 came to 618. Best corrected visual acuity was 6/9. The cornea was clear with normal sheen and transparency. Anterior chamber depth was normal, sense 1+, and flare was absent. Iris was brown in color with irregular pattern. Pupils had irregular margins, almost round and mid-dilated. Lens, IOL is in situ and centrally placed. Fundus appeared to be normal with normal red glow, clear media, and disc margins well defined. As you can see, we have the pre-operative picture of the fistuled pupil and post-operative day 1 after IOL has been placed in situ. Post-operative management, topical drugs right eye. We started the patient on steroids, dexamethasone, eye drops 8 times a day for 1 month in a tapering dose, with antibiotics, moxifloxacin eye drops 4 times a day for 2 weeks, cycloplegics, homatropine 2% eye drops 2 times a day for 1 week. Orally, he was started on steroids, tap prednisolone, 40 mg OD for 3 days for 2 weeks in a tapering dose along with antacids. Antibiotics, tap ciprofloxacin 500 mg BD for 3 days. Anti-glaucoma, tap acetazolamide 250 mg BD for 3 days with anticoagulants, which was started same day after surgery, and immunosuppressants, tap sulfasalazine 1 gram BD. So this type of cataract surgery, phacoemulsification, was performed for the first time at Mahatma Gandhi Hospital under topical anesthesia with the use of iris hooks in the patient on blood thinners. So it has been seen, it can be maybe the first surgery in Rajasthan as well. We're still reviewing the literature for it. Review of literature, epidemiology of cataract in India. Cataract is the most common cause of preventable blindness in developing countries. Cataract surgery is one of the most performed surgeries in the world. Blindness due to cataract presents an enormous problem in India, not only in terms of human morbidity, but also in terms of economic loss and social burden. The present annual performance is in the order of 1.6 to 1.9 million cataract operations. To clear the backlog of cataract cases by the year of 2025 and to tackle the rising incidence, 5 to 6 million cataract operations annually will have to be performed as against the present rate of 1.7 million per year. What is cataract? A cataract is a clouding of the natural intraocular crystalline lens that focuses the light entering the eye onto the retina. There are several types of cataract, including age-related, traumatic, and metabolic. Age-related is the most common type, and the pathogenesis is multifactorial and not fully understood. Complicated cataract, the cataract which was present in our patient. Opacification of the lens secondary to some other intraocular disease. Ocular conditions being inflammatory conditions like uveitis and hypopyon corneal ulcer. Degenerative conditions like retinitis pigmentosa and retinal dystrophies. Retinal detachment, glaucoma, and intraocular tumors. Pupil expanders. The expanders is a device used for mechanical dilatation of pupil in ophthalmic surgeries. It provides surgeon with effective pupil dilatation, comfortable surgical performance, and a high safety profile in eyes with small pupils or floppy iris. Nylon or polypropylene iris hooks with silicone sleeves, the ones which we have used in a surgery. You can see the image right there. Take-home message. Good post-operative result depends upon pre-operative meticulous workup of the patient, anticipation and management of challenges during any complicated case. Multidisciplinary approach is required for complete patient care. Always get HLA-B27 done for anterior uveitis. Lifelong follow-up with rheumatologist is a must.